Good afternoon. My name is Adnan Haider, and I have the privilege of serving as Dean of the Boston University School of Public Health. So on behalf of the school and on behalf of the university, welcome. I'm so excited to welcome you to the annual Shine Lecture. Thank you for all of the people who've made this possible. Special thanks, of course, to the Center on Law, Ethics, and Human Rights, to the Department of Health Law, Policy, and Management, and to many staff and colleagues at the School of Public Health that indeed have brought us here today. I do want to start with just a 30-second acknowledgement of the late Professor George Annas, who led the center until recently. His legacy, his contributions, his memory are very much alive and well with us. And of course, we will remember him today as we deal with issues like the ones we are going to talk about that have implications for ethics and law and policy, all topics that he was an expert on. This lecture also honors the memory of Cathy Shine and her dedication to the rights of patients and to the rights of the underserved. So we want to acknowledge that today as well. Now, the lecture today is on a very, very important issue, that aspect of stopping shackling of patients. This is an issue that one can come to this issue from a number of different topics, from an ethical and moral perspective, from the perspective of a dignified care of patients, from the perspective of vulnerable populations, from the perspective of autonomy and patients' rights. And that's why it's so appropriate that a center in a School of Public Health is really hosting this. And I'm also so delighted at the panel that we have collated together. My colleague will introduce the panel, but suffice it to say that professors and academics, nursing colleagues, medical school colleagues are all contributing together to this dialogue. And that is critically important these days. We want to bring, at the school particularly, an interdisciplinary perspective to everything that we do in the field of public health. My role is to both welcome you and eventually I'll bid farewell to you at the end. But I'm very excited to actually introduce our moderator for today, my colleague, Professor Elizabeth McCuskey, who's the director of our Center on Health Law, Ethics, and Human Rights. She is a professor of health law, policy, and management. Her research is on regulatory reforms. She has done tremendous amount of work which is nationally recognized on state-level health reforms and employer-sponsored health insurances. But most importantly, as I've come to know Liz, she is a dynamic leader of our center. She wants to build the fields of ethics, law, and human rights, and this is part of the work that she and her colleagues at the center are doing. Thank you for hosting this, Liz, and over to you for today. Thank you.
Thank you, Dean Haider, for that introduction. And thank you again for joining us today. The Stop Shackling Patients project exemplifies what we at BU talk about as convergent research, which is not just interdisciplinary, but super interdisciplinary. It translates human rights, medical ethics, population health impacts, and institutional management into practice by enacting and implementing policy change on behalf of a particularly vulnerable population, incarcerated patients. The Stop Shackling Patients Coalition makes an especially fitting and poignant topic for the Cathy Shine Memorial Lecture because we're honoring Cathy Shine, whose experience being inappropriately and involuntarily restrained in hospital care had tragic consequences and prompted her family to endow this lecture in the hopes that no other patient should suffer the same fate. So this year's lectures also exemplify what it takes to make a difference in patients' rights, the roles that education, mentorship, institutional leadership play in promoting real change and real impact. And I now have the privilege of introducing today's speakers, the main event, why you are all here. So Neil Singh Bedi is the founder and director of the Stop Shackling Patients Coalition. He is currently a fourth-year medical student at the Boston University School of Medicine, and his work lies at the intersection of public health and clinical care, with a vision to make the health system more sustainable, effective, and equitable, and who just matched with his first choice residency at MGH. Super, congratulations. We're also joined by Sandra Crosby, who is a medical doctor and professor of medicine at Boston University, as well as a faculty member at the Center for Health Law, Ethics, and Human Rights at the Boston University School of Public Health. Notably, Dr. Crosby was one of the first doctors allowed to travel to Guantanamo Bay to independently examine Guantanamo captives, a role that she still inhabits today. And we are joined by Nancy Gayden, a distinguished leader in nursing, serving as Senior Vice President and Chief Nursing Officer at Boston Medical Center since 2014. She played a key role in the clinical planning and execution of merging two campuses, and led BMC to its first magnet designation in December 2021. So we are delighted to be joined by all three of you today. To start, I'm going to turn it over to Neil Singh so that he can share an overview of the Stop Shackling Patients Coalition and their current work. So please join me in welcoming to the stage Neil Singh Betty.
Good afternoon. Good afternoon. Thank you for the call and response. I always appreciate that. My name is Neil Singh Betty, and I want to welcome all of you, folks here on Zoom, to joining the annual Cathy Shine lecture. My name is Neil Singh Betty, and I'm very excited and very grateful to be here. Before I begin, I just want to take a moment to acknowledge that the work that we'll be discussing today was built from an entire community of some incredible people you'll get to meet today including Dr. Crosby and Dr. Gayden, as well as two of my colleagues and friends, Dr. Nisha Mathur and Dr. Judy Wong. Nisha and Judy are both now resident physicians in New York, and I'm incredibly grateful to this entire team of awesome people and so many others that made this work possible. I also want to take a moment to acknowledge our friend and my mentor, Professor George Annis. I got to meet George 5 years ago when I took the class that he and Dr. Crosby co-taught Health and Human Rights here at the BU School of Public Health. And it's in his memory and in his legacy that we continue this work, and I continue to be inspired by him, and I'm grateful to have known him. And with that, no lecture of the modern day is complete without an appropriate pop culture reference. And so we're going to play a couple clips from the show that I think most of you have seen or at least heard of to set the stage a little bit about what we're really going to be talking about today. We're going to use some of those scenes and discuss them later on today, but I wanted to set the stage a little bit with some of these themes early on. Now, a lot of you might be thinking, this is just a TV show. This is not what it really looks like and not reality of what happens in our healthcare system. Some of you who are clinicians know that this is actually a very common scene of what happens in our emergency rooms and our inpatient units every single day. And early on in my med school journey, I'm a fourth-year med student now. When I was a first year, we go through what's called a clinical skills development course that we call doctoring. And in that course, we're actually paired with a fourth-year med student, and we go into the hospital and we learn how to take care of patients. We learn how to properly put on a stethoscope, how to do a physical exam, and how to interview patients and ask about their medical history. And one of the first patients I got to see through doctoring was a patient who was incarcerated. She was an older woman, barely 100 pounds, and had a terrible cancer diagnosis. And I remember sitting next to her, and every time she would try to talk, she would try to sit up in her bed, and the shackle around her ankle would drag her right back down in her hospital bed. This is a common scene that happens in healthcare systems all over the country every day. Later on that month, when I actually got to see my first patient that was incarcerated, I went back to Dr. Crosby. And Dr. Crosby had taught a class that I took the year before I started medical school, and I just happened to strike a conversation with her about this patient that I saw, and she was actually the attending overseeing my fourth-year preceptor at the time. And Dr. Crosby shared this article that was written by one of our internal medicine residents at the time, Dr. Tyler Lescure. And in this piece, Tyler talks about the process of taking care of one of his patients who was in our ICU, who happened to be incarcerated. That patient went into cardiac arrest. And in this piece, Tyler walks through the process of running the code for that patient, trying to get their heart beating again. And with every compression that Tyler did, he could hear the sound of the shackle against the hospital bed. The patient eventually died. and the title of Tyler's piece was "No Patient Should Have to Die in Shackles." Now, a lot of you might be thinking, we still do this here in America? Yes, we do. And the more I was able to dig into this and the more I learned about the practice of caring for patients who are incarcerated, I came to learn that up until the last decade, it was common practice for us to shackle people who are pregnant while they were giving birth. I don't feel like I have to go through this, but for the sake of completion, shackling is horrific for so many reasons. It causes physical and emotional harm to the very patients we're trying to take care of. It interferes with our capacity to care for them, do things like a physical exam, transfer them from a gurney from an ambulance to a hospital bed, get them down to surgery quickly, get them down for the imaging that they need. And it causes a significant degree of moral injury to us as members of the healthcare team, especially our nurses who are at the bedside 24 hours a day, 7 days a week, taking care of these patients and seeing the condition that they're in. But more than all of that, it's a horrific violation of these patients' basic human rights and a fundamental affront to their human dignity. Early on in this process, when we started to dig into the problem of shackling, I had the opportunity to speak with some people who were formerly and currently incarcerated. And I asked them about their experiences with the healthcare system. And I'll never forget one of the quotes from one of the gentlemen I got to speak with. He said, "I hate going to the hospital, but I really hated the shackles because they took away my humanity." And I don't think there's a better quote to describe that scenario. The purpose of our lecture here today, and the reason that we're all gathered, is to talk about the importance of patients' rights. And I'm here to argue that it is our responsibility as members of the care team, but our responsibility as a community protecting public health to protect the basic rights, the basic human rights of the patients that we take care of. Because everything that happens to them, especially while they are in our care, is our responsibility. Patients' rights are human rights. And as any human rights person would do, we go back to the fundamental human rights doctrine. I didn't know these existed before I started medical school. But when we were talking about this early on, I came to be introduced to what are called the Nelson Mandela Rules. And the United Nations has a best practices document for how do you make sure that the rights of people who are incarcerated are protected. Now, this is not to say we don't violate a lot of these fundamental human rights on so many scales, especially now, but I've cited many of these rules throughout the last couple of years when talking about this issue with people. And the rule that I cite most often is Rule 47, which says the use of chains, irons, or other instruments of restraint which are inherently degrading or painful should be prohibited. I've never met anyone who doesn't agree that the use of shackles is inherently degrading and painful. So, I shared with you that case that I had early on in medical school, and a group of us got together under the mentorship of Dr. Crosby and Professor Annis, and we were like, what can we do about this? How can we fix this problem? Realizing that there are so many things that go into the care for people who are incarcerated, so many different departments and jurisdictions and agencies and officers that you have to convince that this is something we should take action on. And so as any boisterous group of medical students does, we wrote a petition. We wrote a petition to Boston Medical Center in a very noisy, boisterous way and sent it to Nancy's inbox, and we said, Boston Medical Center, you should do better. We can improve the care for patients who are incarcerated. We can do something to make sure no patient ever dies in shackles again at our healthcare system. Now, we didn't really know what would come of this, but the policy that we wanted to implement actually got a lot of traction and helped us build momentum to get resolutions passed in the Mass Medical Society, the American Public Health Association, and eventually the American Medical Association, helping to increase the state of the dialogue around the country, not just about the use of shackles, but about how we care for people who are incarcerated and how we care for people who are vulnerable. More than that, we were able to actually join with the leadership at Boston Medical Center, much in part thanks to Nancy, who you'll hear from later today, and actually redesign our policy for care for patients who are incarcerated. Now, before this policy existed, we could advocate for a patient's shackles to be removed if they need to go down for an MRI, if they need to go for surgery, if we need to do an exam. But what this policy allows us to do is it lists a set of special circumstances. If a patient is sedated and intubated, if they've had a stroke and quite literally can't move their limbs, if they're terminally ill with a cancer diagnosis and can't get off their bed, we can advocate for their shackles to be removed simply because it's the right thing to do. And at the time, this was the first kind of its policy in the country allowing for compassionate shackle removal. And since then, other health systems in the Boston area and other states have started to adopt similar policies, and more than that, interrogate their overall policies for the care of patients who are incarcerated. Early on, when I was sharing about sort of my first-year med student experience, I got to have a lot of conversations about why I felt like our system needed to address this issue. And I often got a lot of pushback, especially from some of our own attendings and deans who said, you know, this is great and all, but should a med student really be the one who cares about this? You should wait until you're an attending. You should wait until you have some real backing from your institution to address problems like this. And I hated when people said that, and I wholeheartedly disagree. We as trainees within our system should be the ones who are at the front of leading change for our systems. 20 years from now, 50 years from now, when I am going to be that attending, we are the ones who are going to be responsible for how our systems function. They are our systems to inherit. And so yes, of course, we should design the systems of the future because the patients are ours to take care of. So over the course of the afternoon today, we'll go through two sort of broad questions. We'll discuss what we've been able to learn over the last couple of years, and then also take a little bit of time to think about where we go from here. And we'd welcome all of your participation, both here in the room and on Zoom, to think about how do we keep pushing this momentum to bring change to other healthcare systems as well. And just to introduce this now, not only have we been able to help other healthcare systems adopt policies for their individual hospitals, but we're also supporting some work in California to actually help legislate this at the state level. And in February of this year, we were able to support Initiate Justice, which is a nonprofit organizing group in California, bring a bill to the California State Legislature taking a generalizable version of the policy we passed here, trying to make it state law for the entire state of California. And with that, I'll pause there and we'll join together.
To invite Drs. Crosby and Gaydon to the stage for a discussion and group conversation. When we have about 20 minutes left in the program, I will turn to the audience for questions, and I would ask our Zoom audience to submit questions through the Q&A button at the bottom of your screen. Thank you.
Whoa.
Just, yeah. All right, chairs. The director's chairs.
Exactly. So we don't need.
So coming off of Neil's presentation, Dr. Crosby, I'm going to start with you. When the students first approached you about this full-throated petition and bold idea, what were your initial thoughts and reactions?
Great question. Well, you know, first of all, I've been attending at Boston Medical Center longer than Nancy's been here, like 30 years, and I have witnessed scores of incarcerated patients who were shackled with metal shackles while critically ill, intubated, at the end of life, dying, and I've even seen dead bodies in shackles who haven't been removed. And so I will tell you, it was a moment of self-reflection that I've been witnessing this, and I certainly hadn't done anything meaningful about it. So I was actually I was humbled personally, but really excited when, you know, Tyler Lescure, who was one of my trainees, came to me and talked about this experience of doing CPR and hearing the shackle hit the bed with every compression. And then shortly thereafter, Neil Singh and his group of students were passionate and just fiercely dedicated to making a change in this practice. So that was really exciting. But again, you know, just humbling. The power of trainees and students is it just was really remarkable in this case, but in so many cases. Now, did I think this was actually going to work? Professor Annis and I discussed this, and he's like, nah, lawyers will never let this happen. But Neil Singh and his group of students were very thoughtful and organized and made what I thought, and Nancy will comment, a really powerful case for making a change. And I thought, if it's going to happen anywhere, it will be at Boston Medical Center, who has a long-standing commitment to taking care of vulnerable patients, including incarcerated patients. If it doesn't happen here, it won't happen anywhere. So again, initially, I wasn't so optimistic, but as time went on, and we had a tremendous collaboration with hospital leadership. And that doesn't always happen with human rights projects, I can tell you. And I just think it was, an amazing, successful project that, thank you to the so many people that participated and were responsible for it.
So one side of the equation has to be this kind of amazing motivation, but working on behalf of incarcerated patients, a largely marginalized and often ignored patient population. Dr. Crosby, you have worked with those patients extensively, even before this project. What has drawn you to work with this patient population in particular?
So, great question. As I said, Boston Medical Center has a long-standing commitment to vulnerable populations, and I've been documenting violence in prisons for probably decades now. Prisoners or incarcerated people, I think, are amongst the most marginalized of marginalized populations. Not even to talk about the circumstances that led them to be incarcerated in the first place. But prisons are places of violence, they're places of medical neglect, and places where people suffer from injuries and even death just for being in carceral settings. And unfortunately, health professionals are part of that violence. It's been documented that misdiagnoses, delayed diagnoses, premature deaths are partly contributed to medical neglect, stigma, and fear on the part of healthcare professionals. And that actually translates to when incarcerated people are cared for in hospitals, that stigma, that neglect, and that violence. And I think we kind of saw that on the clip of the pit. And this is a reality in our systems. And so I've been very, committed to the plight of incarcerated people. And this project is like a dream, honestly, come true, beyond my wildest dreams.
And I think what I've heard so far and what I know of the project is that the dream and the motivation is not enough, particularly when you're dealing with human rights and with marginalized populations. That mentorship seems to be essential to be able to harness that kind of energy and inspiration. So, Dr. Crosby, can you reflect on some of your experience mentoring students, or the role that you think that mentorship outside of the classroom and outside of even your clinical practice has played for you?
So mentorship is so critically important, and honestly, it's one of my most favorite parts of the job is mentoring students like Neil Singh and his group, and just watching these tremendous successes. And who I think it's one of my favorite investigative journalists is Nicholas Kristof from the New York Times, who would say, in every classroom there are people that will change the world. You just need to let them know their voice matters. That's paraphrasing. And I truly believe that. Mentoring has just been inspirational. And, practically, in human rights work, it's also a little bit self-serving because, doing this work for so long, I, speaking for myself, will often just get a blind eye or develop biases. And then to have a student come along and say, wait a minute, why are we doing this, is just so powerful. And yes, mentoring has just been outstanding and
It's
really great.
And so when I'm thinking about the role of education, mentorship, and students, we all want to do whatever we can to help you shine. Sometimes we need you to show us what what we already think is important. But when we're trying to translate it into something real and affecting all kinds of other people, that's where I think this coalition has taken some steps that are really, really important. And so as an institutional leader, Dr. Gaden, I want to turn to you. When the students brought this project to you at BMC, what were your initial reactions? What were your thoughts?
You didn't have to do a petition. I would have met with you anyway.
That's my fault.
No, it's okay. Yeah, it was, the letter was sent to the president of the hospital, me as the chief nursing officer, and the chief medical officer, among a couple of the other people. And the CMO and I, Dr. McEnany, we just quickly, said, okay, let's just have a meeting with the people and we'll be done. And mostly it's because we focus so much on employee safety and workplace violence. And so we thought that the medical students might be naive in terms of what they might ask of us, and which would have to be balanced against the staff safety. Mm-hmm. And so I remember the first meeting, I remember where we were, and this small group of students with Dr. Crosby, we met in a conference room, and we brought actually, I think to the first meeting, the attorney, right, and the head of public safety, and Dr. McEnany and I, and they did this extremely impressive presentation about incarcerated patients. And the one thing I remember from it is, at the time, 50% of the people who are incarcerated, who are walking through our halls with shackles, are just accused and haven't even been tried and convicted, which is just such a sobering thing to consider. Especially, you reminded me this morning about ICE, and there are just a lot of people in that system who are shackled, and we make judgments about that may not have even done anything, and so, or did something very small, and because of their color are dragged through our systems. So anyway, it was a really impressive meeting, and I think, like you, it was this time to say, I haven't even looked at the policy on shackled patients lately. I wonder what's the tone, and it's separate from the patients that we restrain for safety and other reasons. This is really only about the shackled patients that are coming from the prison system. And we quickly realized we could learn a lot from this young group of students, and that we should reflect on this ourselves, and that we would have opportunity to regroup on our policies. I also did not think it would go as far as it has, but we realized that in order to make real change, there was going to have to be a very deliberate process at kind of each of the steps. And it was a great partnership.
It has always sounded to me that it really took off because there was an institutional leadership willingness to both listen and consider policy change, but also to focus on the many things that the institution has to take care of, including employee safety, all the protocols. So, as anyone here who has ever known a nurse can tell you, being at the bedside as a nurse and having that direct role in patient care is really important, and I think lends itself to a scenario where nurses and the nursing staff are often the ones who have to advocate for patients. So can you share a bit about how maybe your nursing perspective informed your institutional perspective about thinking about change?
Yeah, I was smart enough to involve a couple of ICU leaders who ended up being really critical to the implementation of change, that was practical and that we could make sure was consistent across. I was saying earlier, we have I don't know, 1,800 nurses or something. And so when you want to make a change with that many people across years and with the transitions of people coming in and out and the attendings and the staff and the students and coming in and out, you have to really think about how to embed that. I think like you, the nurses got used to, caring for patients who were shackled and kind of were deferring to the officers that were with the shackled patients. They are their responsibility in addition to the clinical responsibilities that the staff have. And so, but Boston Medical Center attracts nurses and physicians and everybody who's attracted to work at BMC is really, inspired by the mission and wants to do the right thing. And so as soon as you raise something like this, like, hey, it's possible for us to do this differently, I think we really had broad support. There wasn't anybody that said, like, I don't know if we want to do it that way. I think everybody was like, okay, now let's just figure out how to think differently in these moments. And so, and when I was thinking earlier about the policy, the simplest thing, the policy was called prisoners. Care of prisoners, and we just made that one change. Computers can do that these days, I don't know, where you just replace, find and replace. And so even just to say it was about incarcerated patients, and then to change the wording to in the policy statement put something about compassionate care. This tone, just small things like that can make a big difference. But it's nurses. I think they care about their patients. They do think of the patient's primacy and respect and dignity, and this was like a natural step to think about. And then I think the logistics were the thing that took a lot of time to figure out how do we embed it in a way where everybody will be consistently evaluating a patient for that. So yeah.
And if I may, just like that notion of being naive. I still think I am, about most things, right, in the context of how healthcare systems operate. And Avi's our director for the medical ICU nursing team and is a fantastic human being and is the reason that this policy was designed the way it was and actually it was implemented. And I think one of the things that we learn early on as med students, you're like, oh, you're a med student, you're ready to go to med school, you're gonna be a doctor, it's gonna be great. You don't know anything as a first year med student. Some days now, I still feel am I really ready for graduation? I'm 49 days away. You still have this sense where you're there is so much to learn and so much to do, and you can't tackle every single systems problem and address every issue for every patient all day, every day. But what you can do is go to smart people and say, there's this one thing that's been really bugging me, and I feel like we can do something about it. And then you work with really smart people who give you advice, right? Who are your mentors and say, here's one way you can approach it. Here's one person you should talk to. And that builds a web of knowledge that extends far beyond myself, Nisha, and Judy into really a group of people who are they might not even be the ones who are right at front writing all the emails and sending all the Zoom meeting invites that they've gotten from me, but just who can support you and give you knowledge. That was more important than anything, I feel like.
And I think that's so great, framing for, we did try to have the right people at the table. We had the senior most person in charge of public safety, the senior most attorney, the chief medical officer, me. And so, but we are the ones who can squelch something or try to give it life, right? And I think we all had the same commitment, but it really was the work that you and your team of students had done to frame it, because you made it easy for us to say, wow, this is the right work and we can probably figure out how to get there together. But at first it was, don't do that again, don't do a petition.
Well, now I can just email you.
Exactly.
Yeah. I got the VP speed dial.
Oh yeah, well we've met a lot of times actually. Yeah. And it was fun preparing for this lecture. I looked back at your presentation and the first few emails that we exchanged, and it just reminded me, how far we've come. And I was telling Neil earlier that it's time to revise the policy. We revise hospital policies every 3 years, and it's been 3 years, and so we should regroup.
Well, and I think naming it the Stop Shackling Patients Coalition really accurately describes why you've been able to make change in policy, why you've been able to translate the things that you learn in health and human rights, the things that you learn in medicine and patient care, into action at an institutional level in healthcare, in a major healthcare system. And so, Nancy, as the person in leadership, I think you're typically the one who has to bring all the parts together that would need to be involved in decision making, but also in implementation. Can you walk us through all the parts that really needed to be involved in making a change at a health system level?
So I think we started with the policy and sort of reworded the part that we had to just make it reflect more of our philosophy around respectful patient care. It was clear that the public safety leader was going to have to start to work with the jail system, the prison system, and the leaders there to figure out like what would be the communication that we would have to do in order to be able to request that the shackles be removed. And we all learned that we can't take them off. We have to have them take them off. So that was one thing. The attorney was, I think, there really for support, but we didn't really need too much, I don't think, of his input. I think probably the most important thing was, policies are one thing, but people don't, normally run to the policy and read it. And so that was really the work that you and your team did with Avi. Because what we did was we put questions into the EPIC system, into the computer system that the nurses use. And we're used to doing assessments every few hours for all sorts of different things. We already had questions that existed for patients who were shackled that had to do with their, how well their circulation was, whether their body was aligned. And so we were already doing like nursing assessment questions. And so the thought was, okay, well, that is where we can add questions to evaluate whether the patient should be evaluated for taking them out of shackles, with some specific questions about, you put the slide up, about them being either sedated or at end of life, being unable to, mobilize. And so now, when a patient is shackled, those group of questions come up for the nurse at every shift. And they have to re-look at, like, is this a patient that could be referred to the attending physician for someone that meets the criteria for being unshackled? And so every single shift, the nurses have to think about this, and then they have to answer the questions, and then they kick it to the attending physician if the patient meets the criteria. And then we have a whole lot of resources at the end of the policy, all the phone numbers and names of all the people in charge of the different prisons and who the attending physician would reach out to make the request. And so I think we tried over time to put together enough support so that the people at the bedside in the middle of the night would have what they needed to go through the decision tree and to contact the prison system, lieutenant, or I forget what they were, different call it, but so yeah, I think the important thing when you want to make things consistent for every nurse who's been a nurse for 20 minutes, 49 days from now, a doctor who's been a doctor for 1 minute, all the way to really experienced people, you do have to embed some sorts of forcing functions to be, in order to be consistent. So I'm proud of that work because I think that has helped other organizations to think about how to implement.
And if I can ask you a follow-up, did you anticipate resistance either to the concept or to the implementation from any particular section of the healthcare system?
Well, we knew that the prison officials their number one job is to keep the prisoner from hurting anybody or from running away or from any kind of bad thing happening to them. So we always assumed, and we were correct, that they would be the not barrier, but
hardest
challenge, the challenging piece. Yep. I was never worried about anybody in the teams being a barrier, but I've also had plenty of examples where I tried to do something and it wasn't designed well enough to really work, and so I was conscious of trying to make sure it was kind of like foolproof from that end. But we never. Did you ever have anybody that was responding poorly?
Not responding poorly. Bill Gibbons, who I love dearly, is our director of public safety. And I remember at the first meeting, I think he was a little hesitant, which appropriately so, right? From the perspective of protecting patient safety, staff safety, and safety of the patient themselves, he was like, well, what if something bad happens? And I got to meet with Bill. The list of people to contact itself is there. We're trying to streamline that communication between BMC and some of these facilities. And he's now like one of the largest champions of the policy. He's like, I love that we do this. The nurses tell me it's great. People reach out to me. And I think when you, like you said, right, when you frame something so clearly like, hey, I just don't want someone to die in shackles, it's really hard for people to say no.
I don't want someone to die in shackles, but I understand that you have to keep your people safe. Like, you know what I mean?
Yeah.
So that so you sort of take the air out of the room with
Yeah.
the person being, but like, but what? You know, right? It's like always been those two things.
I mean, other than the energy of naivete, what did you find anything surprising about working with a large health system to do something that is both human rights based and also fairly discrete in its scope? Like it is a one policy change, but it comes from something so much bigger.
Yeah, I would say two things. One, sort of surprising that I always had hope that something would happen. What was, I wasn't sure. But I was so pleasantly surprised by how welcoming the leadership was. And I think I've said this to everyone here and so many people as I've been able to talk about this. If we had taken the same approach at another healthcare system, it not only would not have worked, but there would have been repercussions for us as students as to how we approached addressing the policy change. And I think, obviously Nancy and Avi, Dr. Gayton and Avi, who I got to work with so closely, but even like Dave McEnany, who's like our CMO, he sat down at the meeting and was willing to listen. And there are very few places in the country, I would argue, where the chief medical officer of a health system this big is willing to sit down and just listen, right? I think the other thing is, as someone who now has a little bit of a better understanding of how the healthcare system operates, we changed the policy like February 2023, something like that. And I was like, oh, fantastic, we did it. Like, it's done. No one's ever going to die in shackles again. And I'm a little bit older now, have less hair on my head and some more gray hairs on my beard. And I can tell you that, like, passing the policy itself was only like step 1 or 2 of what is going to be many more steps of like, how well is it actually implemented? And like, how much do the nurses and the residents and the attendings know about the policy? And how well do other health systems respond? How are they incorporating it? There's so many more questions. And I think that, I guess it's some degree of maturity of knowing that you can do a little, but every time you do something, you realize another couple dozen doors open for action. It's just fulfilling also. It just means that we have more work to do, which is good.
I think also I think we have a Hawthorne effect, right? Because when nurses are confronted with these questions every single time, I do think it makes you think differently and reminds you about the humanity and what can you do to make the patient more comfortable. And maybe it isn't unshackling them, but maybe it's just recognizing that that you can handle something differently. And so I think it wasn't just that it is discreet, but it isn't only that. I think it has broad impact.
Changing the
Don't you think?
culture.
Yeah. Yep.
Of how we approach people who are incarcerated.
So how do you think, and this is probably for Dr. Crosby and future Dr. Benny, how do you think having the grounding in human rights as a doctrine and discipline changes the way you approach both patient rights and maybe even like systemic change?
When I first I signed up for Dr. Crosby's and Professor Andis, they teach health and human rights at the public health school. I signed up because I was like, oh, this would be cool and like give me a different perspective. And for a long time, I thought human rights was like you sit in a room and you read books and you like talk about it over a chalkboard, but then there's no application. And I was so wrong. I think for me, when you base your work, when you base your arguments, when you base your decisions on human rights, you're really thinking about like, what is the gold standard? Like, what is the best we can do to defend someone's humanity? And that's essentially what we're doing here. This is human rights in action, right? It's like, yes, there's very clear documentation from the United Nations that like, this is what human rights are. But for me, as someone who's transitioning into a more formal role as a clinician now, I have a basis of saying that we can do better. And through this, it's a very, very small proof of concept relative to all the other human rights issues to be addressed. But it's proof of concept that you can use human rights as a valid argument for doing better for your patients. And that to me is like my biggest lesson from all of this.
And Dr. Crosby, what drew you to human rights? Because you're medicine first and human rights as like your perspective. What did you initially find so attractive about human rights that you were going to make it your life, make it your life?
Well, I think looking at medicine and patient care through a human rights lens, which is uplifting and defending people's dignity and humanity, kind of underlies everything for me. That's how I practice medicine. That's how I teach. Try to live my life that way. And putting it into action, as Neil Singh and his group did, is just amazing and beautiful. And I will say that usually this work is takes forever, and what I like to say is it takes grinding perseverance. And I say that for many projects that have been going on for 20 years. But this, really with the collaboration of the hospital and the fact that they embrace this human rights approach to caring for incarcerated people, it really happened pretty rapidly in the human rights field. So, but again, it's uplifting and upholding and protecting people's dignity and humanity, no matter who they are, all people.
And Nancy, was there anything about this project coming to you from a human rights perspective that made it easier or harder for you as an institutional leader to bring together the people that you needed to implement?
It's so foundational, isn't it? I mean, it's really hard for people to say no to a meeting if that's going to be the core.
Meeting about human rights.
Exactly.
Like,
can't do it. I got other things.
Yeah.
Right.
I have a conflict.
I mean, I think nursing is really embedded in people and in humans, and unlike the physicians that we work with who are really trying to figure out the diagnostic path and the way to make people well, we in my profession, we are helping the patient to respond to the illness, managing their symptoms, managing their side effects, and then working hopefully with their family and even their community. Sometimes it's kind of like that's our bend, and it comes completely from seeing everybody as an individual and everyone as a human being, and within that, I think, really trying to protect people's dignity, especially people who are marginalized, who we marginalize, by the way. That's why they're marginalized,
Yeah.
So
Yeah, mirror to self.
Exactly, yeah. So.
Well, so where do we go from here? Let's pick up your slide. What are next steps? What are your hopes and dreams, and how can we help you achieve them? This is for all the panelists.
For me, at least, I think the perspective now is one, how do you get this policy to be well implemented at just like one healthcare system? And we're working on that now. And even things like communicating with different corrections facilities, like that's my final task of med school, is just like making some phone calls and like getting to know these people on the ground at some of these facilities and say like, hey, there's a team of us at BMC. We want to do better for the people at your facility, and we want to help care for their health. How can we work with you in building those relationships? I think second is helping other hospital systems who want to bring similar policies to their facilities, and that's been an ongoing process where I've met with people and they're like, well, how'd you answer this question? Or like, how'd you tackle this? Or what would you say in response to this email? And that's been very fulfilling, because I feel like I don't know a lot about most things, but when I feel like I can have a meaningful contribution there, that's been helpful for myself, Nisha and Judy. I do think at some point in my lifetime, I want to see to it that no one dies in shackles. And I think that's a feasible goal. I think the state level policy of having hospitals really think about this so that there are policies in place everywhere for patients to be protected this way. Like even with shackling someone while they're in labor, now looking back, you're like, oh, well, of course, like why would we shackle someone who's in the middle of childbirth? It seems like it makes sense, right? I fully believe that we will reach a point where either through state-by-state legislation or perhaps with a different administration, national legislation, we will be able to look back and say, I can't believe that people were kept in shackles in our ICUs until the moment they died, and sometimes even after they died. I don't know, I have no answers in terms of like how all of that works, but that's what we're here to do. We're gonna figure it out. I think oftentimes when people ask me, they're like, they present something, or even if we're talking about other problems, and I'm like, we're working on it. I can't say that it's all going to be perfect tomorrow, but we're working on it, and we will continue to do so.
I think we need an episode of The Pit.
You know, that would be so
I
great.
mean that. I really think so.
Yes.
Yeah.
Because like that's a big audience.
Yeah.
We would be so good.
Okay.
Oh no,
as
we
they get my
wouldn't be
good
on
side.
it. We would just tell them what to do. But that's something a little bit more like public. Like that would be cool for people to see it in action. How it could play out to unshackle somebody near the end of their life.
Who would play you? No, okay. Let's.
I like
okay,
that nurse. She's good.
Maybe we can do that in Q&A. So, Sandra, where do you want to go?
I just wanted to add, beyond the Stop Shackling, we at Boston Medical Center, another plug for Boston Medical Center, have fabulous faculty and colleagues who are working on other areas of improving the humanity and care of incarcerated patients. And Dr. Nicole Muschero is here. Dr. Ann Beckett, I don't know if she is here or not, have both been working tirelessly to improve the care by creating standards for care of incarcerated patients, increasing their right to incarcerated patients' right to privacy, the right to have a healthcare professional, and helping to facilitate compassionate release when people are qualified to do that. So it's not just shackling. Mm-hmm. Our institution is working on many fronts to improve the care and humanity of these populations. And the other thing I'd like to do, Neil's saying, I'd like to get rid of metal shackles entirely. Like, they really have historical roots back to slavery, mm-hmm. and really represent control and degradation. And we just kind of keep this going. And why can't we find some other way, like in the Nelson Mandela rules, to keep people safe and use the least, possible form of restraint that's necessary. So I'd like to get rid of metal restraints totally.
In the hospital, we use leather for
Right.
our top-tiered restraint, and they work just fine.
They work just fine.
And they are not as hard as a shackle.
Exactly, exactly. And that's, incarcerated patients always come with metal shackles, whereas when we restrain patients in the hospital temporarily for a safety or medical reason, they're never in metal shackles.
That is
they're,
correct.
They're in soft restraints.
Even the most challenging and worrisome behavior restraints, we use leather.
Yeah.
Well, and because this story starts at school with education, what role would you like to see human rights or the lessons of this coalition play in medical education and public health education and nursing education going forward? You only have 49 days left, but please go ahead and change the curriculum.
I would love to. I think first of all, not another plug for BU, but another plug for BU. I think of all the medical schools, we arguably do the best job for students to actually have a place for advocacy in their curriculum already. And I think one thing that we've been able to do is just have that space and time where this kind of work is respected, and you have mentors who are willing to spend time with you, which is such a privilege, right? Most schools don't have a phenomenal public health school with a Center for Health Law and Ethics and Human Rights, and have Dr. Muschero, and have Dr. Beckett, and Dr. Cruz, and so many other people that I could name who are of course I'll grab coffee with you, and of course I'll sit on Zoom with you and talk to you about this. I do think, to some degree, as time goes on and the poor outcomes of our systems are only more abundant, that every healthcare system professional, whether it's a nursing student or a medical student or a PA student, will find something that they're this is what keeps me up at night, And when I sit down and get to write this, have been thinking about an essay where I'm I just want trainees in healthcare systems to be able to look at something and say, I can do that. It might not be related to incarceration. It might be related to climate change. It might be related to how we treat people who are immigrants. There's so many things that we need to address, and everyone can't do everything. But if there was one thing I wish every medical school dean would know is create space for your students to learn really deeply about a very narrow issue, and then give them the power to do something about it, right?
And I don't think it's that different for nursing, and it's not even all about nursing students, but even just in the hospital to really hear the voice of the frontline staff, the challenge that they're dealing with and the things that keep them up at night. And I mean, we have to like kind of recommit and renew our vows all the time about making sure that their voices are heard and that we do create the structure around them to have them be successful in a change that can make a difference to patients, all kinds of patients who we could do better with.
And I think human rights should be more fully incorporated into medical education on all levels, both in school and in residency training. And it's not, unfortunately, at this time. We have people that seek it out, but it's not required, and it should be a formal part of training. And I love what Neil Singh said about finding something you're passionate about. But just, on a human rights front, in today's world, like today, there are so many overwhelming human rights problems. I mean, that it's paralyzing at times. And just to help people, as Neil said, we can't change everything, every issue, but we might not even be able to make something right, but we can probably find a project and make something better, even in small incremental steps. And it's important to think about so people don't get overwhelmed.
And that notion, it is paralyzing, right? Looking at the news and you're like, there's so many terrible things happening every day. And we're all aware of them. That's what makes it hard also, is now with the access we have, we're aware of so many terrible things happening every day. But being able to wake up and look to your left and look to your right and see so many people who care so deeply just about their one thing, and they're like, I might not be able to fight the wildfire in California or stop the bombs in a certain part of the world, but right now I know that advocating with this group of people, having this conversation, tomorrow one less human rights violation will occur because of the work that we're trying to do. And is that perfect? No. Is it enough? If we keep doing it, yes.
I think what you said is important too. A lot of people have made commitments to their own practice. Like, I will make sure that there's an interpreter whenever I'm speaking with someone about, who doesn't speak English for their first language. That's a very important thing. And even better if you can talk about that with your colleagues, advocate for other patients that aren't the ones you're caring for, right? Then you start to have more broader impact just from your own, your own advocacy in your own areas.
So let's, now that we know the true power of bringing other voices in, let's turn to audience Q&A, have a discussion. I'd like to ask our virtual audience members to submit your questions through the Q&A button at the bottom of your screen. And for our in-person folks, I believe we have a microphone that will be coming around so that everyone can hear you. I'd like to start with former Shine lecturer, Heidi Coomer.
Thank you very much. And first of all, congratulations. That is a real win, very impressive. On all counts, also on behalf of the medical center where I trained decades ago, very proud to say that you listened and were amenable to making changes. That's terrific. A couple of questions. One is, do you think the fact that these individuals always came with minders or an officer made a difference, as in there is somebody there who's already watching them, since the idea of they could escape or harm somebody or somebody else, whether that made a difference? And going further, do you think eventually this may translate to the general restraint orders that still do happen? And go back to Cathy Shine, who was absolutely compos mentis when she was physically restrained against her will to be intubated. We still have patients in the ICUs who are restrained. We deal with staffing shortages, which is one of the issues where we say, well, nobody can really sit there and watch this patient, make sure that they don't harm themselves. Do you foresee at least the awareness of what it means to shackle or restrain somebody sort of translating to other questions about, do we really need to restrain this person? I know in critical care they're starting to do some, or they've done some studies showing that restraining somebody to prevent them from extubating themselves versus not restraining them hasn't made that much of a difference. So I wonder how you think that may have made a difference here.
You know, I think we saw long-term care basically go restraint-free, right? About, I would say, 15 years ago, a long time ago. So the skilled nursing facilities, nursing homes, never use restraints. And you know, people fall and things happen when you don't restrain, but it's known that it's a terrible practice. At BMC, we very, 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 very seldom restrain people. It is much more unusual than it used to be. We use a lot of one-to-one observers, a lot. We also use now 24 cameras in patients' rooms to try to keep them safe and keep them from going anywhere without, you know, actually physically. We can't even put the side rails on a bed up without, that's considered a restraint nowadays. So I think the industry has come a very long way in what sounds like was a terrible thing for the woman this lecture is named after. And you know, we do have a lot of patients who we are working through their guardian, their next of kin, their healthcare proxy, to make sure that if the patient can't speak for themselves, that we're making decisions with their chosen person. We very seldom restrain people except for very big behavioral emergencies that we can very quickly resolve with medication management from the physicians that are on. We have a 24/7 behavioral response team now with nurse practitioners that are staffed by nurse practitioners who help as much as we can to avoid those situations. We page them, stat page them so that they can come and de-escalate before we get into that moment. And I was just looking at data yesterday. We now have a psychiatric facility that is BMC's that's in Brockton. It is 80 beds, and the restraint data in that psych facility is unbelievably low. It has come down amazingly over the last like three years since we've had the organization. They also use one-to-ones to watch patients so that they don't have to put hands on. I'm not saying it doesn't happen. We spend a lot of money on one-to-one observers, more than 100 FTEs actually we use at BMC. So it's a very big part of my budget. It's millions and millions of dollars, but it does avoid having to tie someone down. You can watch them and hopefully keep them out of, from hurting themselves or others, but it's mostly themselves in other ways. But I think it's a great question. It's something we always have to keep challenging ourselves around to make sure that we're doing every single thing we can to avoid having to restrain somebody.
I agree with Nancy, and I think it's important to understand that medical restraints are used for a different purpose than people that are restrained that are coming in as incarcerated patients.
True.
And so we can't really compare those two situations. And I think, one of the criticisms that we had on our original paper of the project was, well, this doesn't go far enough. You should be having, admit people to the hospital, and then the hospital, decide if they really need restraints or not. And we're not trained as law enforcement. We don't know if people are dangerous or not. We can decide and make a medical decision about whether they need to be in restraints because they're too sick, but we can't make a prediction about whether somebody's dangerous. So again, I think it gets back to the least restrictive amount of restraints. I think it gets to not using metal restraints at all. But again, it's hard to compare those two groups because they're really completely different, and they're restrained for different reasons.
And I think the other part of your question was, how does the presence of an officer make the staff feel not scared? I think absolutely, and I think a lot of the staff, a lot of the time, would feel like the patient doesn't need to be restrained. But it's.
I would say I'm scared of the officers sometimes because they're the only people in the hospital that have guns. Sorry.
I know. You're not wrong. Yeah, I think that is a part of what makes the whole thing, the staff feel safe, definitely. And probably that's why it's right for the staff to be the advocates for the person that they. And the other thing is, when I first came, I was taking a tour, and I was like literally, I don't even know if I'd started work yet. One of the ICU nurses was taking me for a tour, and she said that in that room is a guest of the governor. And then about 5 rooms later, she said that patient is a guest of the governor. And I was like, wow, the governor's got a lot of guests here. and it was they were patients who were incarcerated. That's what. And I think also just broadly, the nurses never try to figure out what the patient did wrong to put them in that situation. They just want to care for everybody because that's the patient in front of them, and that's the patient who has whatever diagnosis, and that's what they're focused on, which is the right thing. The right thing.
So speaking of that difference, while you were talking and while we were watching the pit, I felt acutely aware that the officer was the one with the key to the shackles. The medical staff couldn't do anything. So I'd love to hear more if you've had diplomatic dialogues to try to make some wiggle room there, to try to back off of a shackle or to understand better how necessary it was or something like that, because that's one thing that you haven't talked much about that I'd really love to hear.
Yeah, when I was holding on to the policy, the old policy and the new policy, in case I felt like referencing it, the last page and a half is the name of each Department of Corrections, the name of the prison, the name of the warden at the time, the phone number, what kind of prison it is. We really have focused only on like the clinical situation, defining our advocacy around not shackling. Honestly, and I think that anybody else can weigh into this. We never have been in the position of saying, are you sure that with this crime that this person did that we don't even know, whether or not that's the right plan for them. If they're incarcerated in a prison, they come with a guard because the prison's still in charge of them, kind of. And I don't know if that's the right thing or not, but we haven't gotten into that part of advocacy, if you want to think about it that way.
And I think part of going forward is to develop better collaborations with all of the Department of Corrections and their medical departments, and try to individualize care. But that's, again, one of the steps going down the road. I've had some very good interactions with some of the staff, the prison staff, where if I go in and I notice shackles are too tight, I will ask them to loosen the shackles, and usually they're very cooperative and very responsive. But again, in terms of removing shackles beyond
one limit of time.
Right. We right now we're removing them for compassionate reasons, and again, our goal in the future is to work with these Department of Corrections and maybe, again, try to individualize care. Maybe not every incarcerated person needs shackles and 2 guards with guns.
And they, I think we would all agree, they're conservative. Their job, especially the guard at the bedside, he's not the head guard, he has one job, and that is to manage the safety of the milieu there. So.
And when you get to those dialogues, there may be a role for the BMC security guards as well to help be an interface so that your staff feels protected. The DOC can speak the same language. So for down the road.
That's a part of the process right now. If we're going to request that the patients unshackled, public safety is part of the group.
That's awesome.
Yeah.
Of course. Nicole.
Hi, this is absolutely...
Wait for the mic.
Nicole Huberfeld, this was absolutely fantastic and so inspiring, and congratulations to all of you on really amazing work. I'm sitting here thinking about how to make this less of a microcosm and more of a nationwide policy, and the kinds of questions that people might ask because they have this sort of instinctive fear-based reaction to the kind of thing that you're proposing. And I wonder if you know of any data that explains what the actual risk of escape or harm to others might be?
So we, and Dr. Crosby will correct me on this, early on, this was part of the conversation also around who is part of that special circumstances of people who we advocate for shackles to be removed. At BMC, and this is data from one very specific health center, our patient population, we see a couple hundred people who are incarcerated who are inpatient at BMC. Of those, only a subset meet criteria for shackle removal, and of those, only a subset are actually unshackled successfully, because as alluded to earlier, we have to contact the corrections facility at the right time. They have to give approval and then pass down the order to the guards at the bedside. Of everything that we've seen specific to this policy so far, there's been no adverse safety event because of the policy here. Anecdotally, in the news, you will see patient eloped every couple of years, and that happens. But the people who meet criteria from our clinical exam of a sedated patient here who is sedated and intubated is essentially the same sedated and intubated patient anywhere, right? They're not going anywhere. Similarly, there are people who've had strokes and have not been able to move the right half of their body for 15 years. The right leg is shackled to the hospital bed, right? That clinical condition, I hate to say it, but they're not going anywhere, right? You can treat them as human beings. Mm-hmm. Is that still an ongoing concern? Absolutely, right? Public safety will bring that up as well, because at the end of the day, the responsibility of the law enforcement officers accompanying the patient is to make sure that they're safe and that the surrounding area is safe as well. But on a national scale, to your first part of the question, I do think that if we had the chance to just sit down and be this is the example we're talking about. We're talking about the patient who's sedated and intubated in cardiac arrest. They should not have to die in shackles. That is a much more clear sell, I think. But
well, and I remember you didn't even say that to us. You said, "Okay, what are the what?"
Yeah, we asked Nancy.
Well, and then the physicians too,
yeah,
right?
Yeah.
Well, you tell us.
Yeah.
Where are the criteria that you would agree to? And then people were if they're paralyzed.
Yeah.
If they're, you know what I mean, and if they're sedated. And so each hospital really they could have pretty narrow criteria. It would still be better than nothing. Mm-hmm. And then I was looking also at the questions that the nurses answer, and you made them all structured fields. So that's the other piece. We can run reports off that. Here's the number of patients where the assessment showed that they met criteria. Here's the number of those where the physician was contacted. Here's the number that was requested from the prison. Here's the number that were unshackled. And so we can keep watching that too. And then, of course, if anything adverse happened, we would have a different reporting strategy for that. But
to answer your question, there is no national data because everybody in the United States who is admitted to a hospital from a carceral facility is shackled and accompanied by guards. So we're the first institution to actually initiate this policy, even though it's now spreading around the nation. So I think it's too early. I certainly cannot see any danger or security risk from the patients that we've unshackled at Boston Medical Center. But there just is not data out there.
Yet.
Yet.
And we're gonna have a question from our pretty sizable online audience.
Yeah, so this is, we have a lot of questions from the online audience, so I'm just choosing one because I know we're almost at time, but someone is asking about the role for regional interhospital collaboration on this project, and whether there's a role for community advocacy to push hospitals towards more humane policies. And before you answer, I'll just add that someone in the webinar chat said that their cousin is an actor on the Pit, so she will be sharing this with them. So.
Yes.
I will ask that person, if you're listening, to please email us so we can coordinate some kind of comment to the Pit and thank them for mentioning this. To answer the question around regional collaboration and community advocacy, with regards to regional collaboration, there is a group from the MGB system as well as from the UMass system. MGB has a similar policy like this now, thanks to Dr. Alice Bookman, who I believe is an emergency medicine physician there and is incredible. And I think that regional advocacy is very effective because while we at BMC get the vast majority of patients who are incarcerated within the area to get care here, it does apply, right? All out locally, and the facilities are generally the same within the same geographic area. So I do think that's effective, and I think that's something that we should continue working on. With regards to community advocacy, absolutely, and I'm the first to acknowledge that that's an entire arena of very powerful people whose stories we should not only listen to, but like follow. And like if they tell us, this is a better way to do this, that's the advice that we should be following. And there's some folks here at BMC, Dr. Machero, we alluded to them earlier, and then Deb Goldfarb, who've really taken root in the community of advocating. And if there is anyone who would like to, or folks that we can reach out to in the community that would like to advocate with us, like I would love to learn from them. But yes, absolutely, that should be the basis and not like a tangent for the work.
Absolutely.
Hi, thank you. So one of the things that always struck me about this, and I think the first pit clip did a really good job of illustrating it, is sort of the extent to which the prison is sort of infiltrating, right, the hospital. And one of the a conversation that George and I used to have a lot, and I think Sandra, we had it too, is we always saw kind of like the Eighth Amendment and healthcare professionals in the prison setting as what should be an avenue, right, for more sort of dignified humanitarian kind of work and development. But thanks to, your work, right, we've actually seen the opposite, right? Like healthcare workers in these sort of, carceral settings, they're participating in torture, right? They're doing sort of things like, and so I wonder, far be it for me to say, here's some additional work, but can this be taken to extend, right? And do the reverse, right? Take the healthcare setting and push it into the prison setting, right? Instead of the prison setting sort of being pushed into the healthcare setting.
Yeah, you want to lead that?
Yeah, we hear you volunteering to lead this effort. You are a powerful advocate and the writer of persuasive amicus briefs, so.
Yeah, no, it's a really good point, and as we know, prison health has really been taken over by private contractors and corporations, and you don't even have to be board certified to be a prison doctor. So Dr. Machero knows, I think, a lot about this, but we do not have a great health system for prisoners. And as I said early on, we know they're dying of neglect, they're dying of violence, and yeah,
there's more work to do.
There's a lot of work to do, but yes, we'll sign you up, Michael, to lead this new initiative.
I mean, it's a good question, though.
Yeah,
Boston Medical Center has the relationship with the prison system in Massachusetts. That is why we get so many patients who are incarcerated.
Yeah.
And so it's a very reasonable place for us to be, to say, we would like to partner with you a little differently, and we would like to impact on the care, not only, in terms of the continuum of care. We're going to discharge this patient back to the prison. We'd like you to focus on these things, and we want to be more collaborative. And do you need more support in wound care? Do you need, what I mean? Like, where are the places that you feel like you don't have either the expertise or the resources?
Right.
I don't think it's unreasonable at all, and we would be the people to do it.
Right, we would be, and that extends to post-release care,
Yeah.
which is a very highly vulnerable time for people.
Oh, post-release, yeah.
Yeah, post-release. So much work to be done.
And a lot of our patients, post-release, they're seen in our primary care clinics, right? And so that's like another piece that we should think about.
Thank you all so much. In the spirit of more work to do, I'm going to bring Dean Hyder back up to give us your concluding remarks. Thank you.
Wow. First of all, what an amazing, amazing session, both intellectually stimulating, really pushing us to think about important and hard issues, and also demonstrating the complexity of the healthcare system that we live in. These are very, very difficult issues. And as a professor of global health, I was reminded by a couple of thoughts. One, that getting access to care for incarcerated people in itself is a problem in many countries. In other words, folks who are in prison systems don't get to the hospital. In many other countries, we actually have a problem right there. But second, I'm reminded of the apartheid days, and I don't know if you've obviously read about stuff around dual loyalty and this notion of dual loyalty. Michael just raised the question of physicians working in the prison system. And then a very, very important book that came out in those early days about ambulance of the wrong color, because white people and colored people had different ambulances. And if the wrong ambulance was dispatched, it just didn't work for you. So such a layer of complexity to the insights that you've brought. But I think what is really close to our hearts is the fact that change begins at home. Change begins one step at a time. And you all are demonstrating that. And I know the three of you represent a community that has been working together. So first, congratulations. Please join me in thanking our panelists for the tremendous work they've done. I want to thank Liz and the center for the great work that they do and for hosting this. And obviously a thanks to the Shine community that comes together every year to talk about these issues. The School of Public Health is just honored and delighted to host these lectures and these dialogues. This represents our convening and our thought leadership that we'd like to bring to the community. We look forward to hosting many of these. Our public health conversations continue. Our next one is going to be on the 29th of April, if you're interested. It's going to talk about the future of public health in the United States. This is going to be one component of that. Thank you. It's a very important topic. I look forward to seeing many of you there. Thank you for joining us in person and online. And once again, as we leave, thank you to all the panelists and to our moderator. Thank you.